Well, hello, everyone, and welcome to the International Myeloma Foundation's virtual community workshop, our myeloma workshop today. It is absolutely a pleasure to be with you tonight, and we're very, very grateful that you have joined us. This is a very special workshop for many reasons I'll describe as we go forward, but part of it is because we are going to address controversies in multiple myeloma. You know, sometimes I joke, if I put 10 myeloma doctors in a room, I have about 12 opinions. I'm definitely not going to do that tonight. I'm actually just going to bring 2 myeloma doctors in addition to myself. I'm going to introduce them in a few minutes, and we're going to have conversations about some of the challenging questions we have. We're so grateful that so much progress has been made in multiple myeloma, that there are things that we can all agree on about how much progress has been made, but there are some challenging areas that we need to think about, and we're going to be discussing more of those this evening. And so the plan for tonight is I'm going to spend a little bit of time welcoming you, of course, and sharing a little bit about what the IMF is doing. In many respects, sadly, I'm doing this because unfortunately, Robin Tuohy, who is our Senior Vice President of Patient Support, is unable to join us tonight. And she sends her best to everyone. And then we're going to address 3 topics tonight. And importantly and wonderfully, I have 2 world experts in myeloma who have joined us. And not only are they world experts in myeloma, they're also my friends. Don't hold that against them, but they are good people. And we have Dr. Amrita Krishnan, who is the head of the myeloma program at the City of Hope program, which is now really across the whole nation, frankly, but she is based in Los Angeles. And we have Dr. Saad Usmani. Saad, your name is so important, we've put your name twice there. So Saad Usmani, who comes to us from New York, he's the head of the myeloma program at Memorial Sloan Kettering. So this really is going to be, I'm not going to pit them against each other because they're good friends, but this is kind of East versus West, you know, Lakers versus Knicks, Dodgers versus Yankees. This is good. This is going to be a bit of an epic battle this evening. And then for those who don't know me, my name is Joe McHale. I have the privilege of serving as the Chief Officer of the International Myeloma Foundation. So what are the 3 key questions we're going to be addressing tonight? They are as follows. Number 1 is to treat or not to treat high-risk smoldering multiple myeloma. Question number 2, should MRD or minimal residual disease, and if you're not familiar with that is, not to worry, I'll explain that before we get into that discussion, but should MRD guide decisions for transplant and maintenance discontinuation? That will be our number 2 question. And thirdly, CAR T-cell therapy, if you're not familiar with CAR T-cell therapy, we'll explain that. Chimeric antigen receptor T-cell therapy, is it really for everybody at first relapse? Yes and no. And so for each of these discussions that we'll come back to, we'll have Dr. Usmani take the yes side, Dr. Krishnan take the no side, and we'll have a bit of a discussion together, all in good fun together. If you're anything like me, it's very helpful to have closed captioning for a program like this. So we do offer this on this program, but if you look down on your Zoom screen, you have the option down at the bottom where it says show captions to choose closed captioning. You also have the choice there to add, to change the language if you want the closed captioning in English, obviously the language we're speaking right now, but you can choose multiple languages to have that throughout throughout the workshop this evening. Then furthermore, this is meant to be more than just listening to our experts have a discussion. We really want your questions. So please also use the Q&A button that is there. We will be able to have you submit your questions because we're going to take a significant proportion of this seminar at the end to be focused in on Q&A. As many of you know, we really encourage you to ask questions through the IMF, through all of our social media channels. We use we want you to use that opportunity to ask a question. Always just add the hashtag Ask the IMF when you're using social media. Tonight, you can just go directly into the Q&A panel, and we'll be able to take an opportunity to go over the Q&A with you later this evening. And it's great that I have both Saad and Rita to help answer these questions that you have for us tonight. But a couple other things as we go on. You're going to see after the webinar this evening that there will be a survey, and we would love your feedback. We have really tried as much as possible to follow the different kind of feedback that we've been given around these sorts of webinars. And so I'll mention that again towards the end. But even through the session, if you think about things that could make this better, please let us know. Also, if you're having any technical issues, you can also use the Q&A to send questions to our support teams. Those questions get triaged through them. And you can also email their meetings at Myeloma if you have challenges with that. So feel free to reach out if you have any technical challenges. I'd like to spend a minute to thank our sponsors tonight, AbbVie, Amgen, GSK, Johnson & Johnson, Karyopharm, Pfizer, Sanofi, and Takeda, who supported this program with us. Although many people are going to be with us, obviously, in person this evening, we're grateful for that. We know that over almost 1,000 of you have actually registered to join us this evening, that not all of you are going to be able to stay through the whole of it or do want to have a way to review and re-listen to this. So this is being recorded. We will have the opportunity for it to be replayed. In fact, the IMF has so many different videos available to you, and this will also be available to you thereafter. So when you go to the website, there's an area called Publications and Videos that hopefully you can see now, and you can scroll down to that, and the virtual workshop will be there as well. I want to spend a minute taking some time to reflect on one of our co-founders, Dr. Brian Durie, who sadly passed away very recently. Many of you would know Dr. Durie. Many would know that he did innumerable patient meetings along with so many other things for the patient myeloma community. He also did innumerable things for the scientific community. Our classification system is named after him, the Salmon Durie classification, and he was also the chair of the board of the IMF for over 30 years. And he was the reason why I joined the IMF. He was an incredible mentor to me and to a number of other people. I know that one of our speakers in particular tonight, Dr. Usmani, was very much influenced in his career by Dr. Brian Durie. And so we're very sad that we've now lost Brian, but we are grateful that we will continue to his legacy and continue to serve the patient population that he loved so much. Part of that service has to do with our brand new CEO and president. Our president and CEO is Heather Cooper Ortner. We're so delighted to have Heather join us. In fact, I really should say to have Heather join us again. Heather had been at the IMF and was with us back up until 2014, and is now returning. So in many respects, this is coming home for Heather. I hope you feel that way, Heather. She's listening in to us tonight as well. And we took one of her quotes here that I love. I am humbled to serve alongside so many who are making a difference every day for patients and families affected by myeloma, and I look forward to building on the IMF's legacy of impact. And she is inordinately skilled to take on this role, and we're absolutely delighted to have you join us, Heather. So welcome back to the IMF. Just a few minutes about the IMF before we get into our discussion and debate. That the IMF really it has now been present with us for 35 years. This is our 35th anniversary, and it was built from the very beginning by a doctor, his patient, and his patient's wife, and they built with this incredible vision at the time, a mission to improve the quality of life of myeloma patients while working towards prevention and a cure. More recently, we added our vision, which is a world where every myeloma patient can live life to the fullest, unburdened by the disease. That's our goal every day as we care for patients. And the IMF was built on these four major platforms. I won't go through them in a lot of detail, but research. We bring the myeloma community together in the form of the International Myeloma Working Group and our Scientific Advisory Board to really push the envelope of research. Education, like we're doing tonight, whether we're educating someone who is newly diagnosed, someone who's had myeloma for a long time, the doctors taking care of them, the nurses taking care of them, everyone else on the multidisciplinary team, care partners, even the lay public, we are very much involved in education. Advocacy, we work very hard to advocate for our patients, whether it's in Washington, D.C. or all across the world. We have sought to advocate for better access for these amazing therapies that we'll be discussing tonight for our patients, and much, much more. And lastly, support. We have over 150 support groups in the U.S., another 150 across the world that we have the privilege of working with, because we know when patients are empowered, they will have better outcomes. Part of that support, as you see here, is led by Robin Tuohy, and you can see the marvelous group of people who work with her really right across the country. And if you want to learn more about this, you can go to the IMF website, use the interactive map to be able to find a support group near you, or as I'll share with you in a moment, there are multiple ways in which you can reach out to us. We not only have geographic support groups, we actually have several special interest groups. Ones, for example, if although myeloma is typically diagnosed in the late 60s, we know there are many patients with myeloma diagnosed very young or may have very young children, and that provides unique challenges. And so we have a myeloma family support group. We have one, they're actually meeting tomorrow. We have a Spanish-speaking Las Voces de Myeloma support group. We have those who do not have a care partner, living solo and strong. One for veterans. We have Smolder Boulder, which is actually going to be very relevant in a few minutes when we talk about smoldering multiple myeloma. And you can see other support groups that we have there that can be available to you. And we are gearing up for arguably the biggest myeloma meeting of the year. It's the American Society of Hematology coming up literally just in a couple of weeks in Orlando, where some of the greatest research, a lot of that research that Dr. Krishnan and Dr. Usmani will be quoting tonight when they make their case for their topic, has often been presented at this major meeting that we have every December. And in particular, one of the things that I think we want to share with you tonight is that we bring several patients and care partners to the meeting to view all of the research that's coming out through a patient's eyes and ears. And often these are the ones that tweet the most or X the most, and using various different platforms. And so we're going to have 11 of our patients there in person, 4 virtually, and we're going to invite you to follow them as they send out messages and video blogs and other blogs describing the patient experience. And I will note, and you'll see it advertised heavily, that on the last day of ASH, or at least the final Monday night, we're going to have a Facebook Live where I will join these patients and they're going to share what they learned over the last few days. You don't want to miss it. It will be on that Monday evening. You're going to hear more about it. If you have questions for the IMF, as I've noted, you can use social media and use the hashtag #AskTheIMF. But you can also use our newly generated AI chatbot, Milo. So Milo is there 24/7 when Dr. Krishnan is sleeping, when Dr. Usmani is sleeping, when hopefully I'm sleeping, and you can't reach the doctor, no one's answering your portal, you can go straight to Milo. If the dexamethasone is keeping you up and you want to ask a question, feel free to do so. And it feeds off our own website, so the information there is very accurate. Other people like to ask questions of a human and speak to someone. And so we have an info line that you can see here that can be reached electronically and by phone as well, worldwide. Please reach out to us and we can connect you with them. You can speak to them live on the phone or by email if you have questions, and we would be happy to schedule a call or just make a call directly to them. And then towards the end here, I do want to make reference to the fact that we will be discussing several clinical trials tonight. And very often our patients ask us, how can I be involved in a clinical trial? Well, we have multiple methods to do so. One way to do so is on the IMF website. We've partnered with an organization called Spark Cures to have a search engine that gives you in real time which clinical trials are going on, and you can filter it by the diagnosis, how many lines of therapy you've had, for example, or if you have smoldering myeloma versus active myeloma, some of the things we'll be discussing tonight. And we're also happy to help you in all those other ways to walk through this site, or you can use it, of course, on your own. And of course, we always have extensive publications available to you, either in print or online, for every drug that is approved in myeloma. Please subscribe so that you can receive Myeloma Today every week, the Myeloma Minute, and of course on YouTube, so you can see the extensive videos that we provide on a regular basis. And over this last year, we've had several patient family seminars, which is a sort of a 2-day workshop or a single-day seminar or community workshops, and now our final virtual workshop. But next year, we are going to be all across the country again. So please join us for our patient family seminars, whether you're in Boca or Cleveland or Los Angeles or Short Hills, New Jersey, or our workshops that you can see here in Kansas City, Minneapolis, Detroit, Salt Lake City, Portland, San Diego, or Phoenix. On these dates, we would love to have you join us for an in-person experience where you can meet other myeloma patients and indeed myeloma experts in the area. And we are advocating for you as the patient and their partner. And our goal and our policy team, which is really remarkable and have done incredible things, even just in the last few weeks, really are seeking for better access for the therapies we're going to be discussing tonight, eliminating those financial barriers and continuing to push our research agenda forward. And I thought it'd be nice to include some of these pictures of our amazing patients and partners who came to Capitol Hill. They called it Hill Yeah a few weeks ago, and it was really a remarkable event, meeting with many of our government to share the importance from the voice of a patient of the kinds of things that we seek to do. All right, that's all I have to share with you for background. And now I want us to move in to the medical crossfire that you've all been waiting for. Let me preface our comments by the following. This is our third virtual workshop of the year. Our first one, some of you joined us back in March, and we talked about newly diagnosed myeloma. Some of you joined us in the summer in July when we had a deeper discussion about relapse myeloma. Well, today we want to talk about some of the controversies that there are in myeloma, not controversies that we would fight about, as it were, but areas that we still need to understand. I've often said science is really all about the questions you ask. When we train our new researchers, my favorite lecture is entitled, "The Answer is the Question." If you don't ask the right questions, you'll never get the right answers. So we're going to ask 3 important questions tonight. And for each of them, we're going to do the following. I'm just going to very briefly set the context of what the question is, what the essential point we're trying to ask is, and then we'll turn it to Dr. Usmani, who is going to sway you and woo you that the answer must be yes. And then Dr. Krishnan will woo and sway us to prove that the answer is no. And then thereafterwards, we'll have a little bit of a discussion together. We'll do 2 of these questions before we take a little bit of a break, and then we'll come back to do our third question and receive your questions. So please feel free to even now start entering. I see that many of you have done that already. Start answering your question, sending in your questions for us to answer later. All right, what is our first topic tonight? High-risk smoldering multiple myeloma, to treat or not to treat. So very quickly, you remember that myeloma has, if you will, 2 precursor conditions or 2 things that people have before they get to myeloma. One's called MGUS, or monoclonal gammopathy of undetermined significance, bit of a mouthful. It just means that people have that little abnormal protein in their blood that their body is making, but it's not at a level that it's causing any damage. It's actually very, very common. Almost 5% of everybody over the age of 40 will have it. And we typically just wait and watch if it happens to be discovered. Secondly, however, we have this category of smoldering myeloma, where there's more of the protein involved. The key cell in myeloma, of course, is the plasma cell that makes our good antibodies to fight off infection. Now those plasma cells have grown. Typically in our bone marrows, we shouldn't have more than up to about 5% plasma cells, but cancer is just uncontrolled growth. And now there's a little bit of it, as it were, that has reached a point where it's at least 10%. But at the same time, it's not immediately causing damage to the kidney and the bone and the other organs we know that can be damaged with multiple myeloma. And we call that category smoldering myeloma. Even within that category, we've now separated so-called low risk or even intermediate risk and high risk smoldering myeloma, where people are getting ever so close to having myeloma, but they don't have active myeloma yet. And the question is, should we treat those patients? We even had, I'm sure Dr. Usmani will reference it, we've even had a recent FDA approval to potentially treat this group of patients. But we struggle. We don't want to treat too early. We don't want to treat too late. And I'm hoping that Dr. Usmani and Dr. Christian can help us understand, when do we treat and when do we not treat high-risk smoldering myeloma? So with that, Saad, I will pass the baton to you, my good friend. Thank you so much for joining us. And I will let you spend the next few minutes talking to us about, yes, we should be treating smoldering myeloma.
No, thank you so much, Joe, and it's a pleasure to be here with you and with Amrita to talk about these controversial topics. I have to say, I'm just coming off of the heels of the smoldering myeloma workshop, where we spent 2 days talking about each of these things, and I can share with you that we have more consensus on how to move forward than we did before the meeting. So I'm hoping that I can share some of the insights. But kind of building on what you just shared, I think our definition of what constitutes the risk of going from having a smoldering kind of myeloma that can just hang out in the background without causing any grief for many years, versus smoldering myeloma that is just at the cusp of exploding into active myeloma and causing grief to patients in terms of end organ damage. That's where we've been trying to draw the line. And over the past 20 years, we've tried to draw that line just by looking at how much smoldering myeloma you've got by measuring monoclonal protein or light chains or the number of plasma cells in the bone marrow or any early changes in the MRI. But then, more recently, we've also had information on the genomics or the abnormalities inside those smoldering myeloma cells, and whether they can tell us which patients are going to have that progression. And I think we're getting closer and closer. So, just 2-3 years back, we had this validation of the International Myeloma Working Group 20-20 criteria that was initially reported by the Mayo Clinic colleagues, and then validated in a patient cohort of almost 2,000 smoldering myeloma patients collected from the many myeloma centers. So what I'm trying to get at is, I think we have a much better idea of what that high-risk smoldering myeloma group is. But even within that high-risk smoldering myeloma group, unless we add other changes like disease biology or what's happening to the immune system, we won't be able to fully negotiate or tell our patients, negotiate in terms of the data that we have, is that if we have someone who we deem smoldering myeloma, they have 100% chance that they are going to progress to active myeloma in the next year or two. So when I say yes, we need to treat high-risk smoldering myeloma, we have to identify the right patients for that. And I think we're getting there. The 20-20 criteria high risk is our baseline, and we're going to add a few more features to it, or bells and whistles to it, to kind of refine it. But I do feel that most high risk smoldering myeloma patients are going to be treated, moving forward. Going to this clinical trial of looking at subcutaneous daratumumab compared to observation, the Aquila trial that actually led to the approval of subcu dara for high-risk smoldering myeloma patients. I think it's a very important step forward for that high-risk smoldering myeloma patient population, because before this, we could not treat those patients or prevent those patients from getting end organ damage. And from a regulatory perspective of getting drugs approved, I think this was a very important step. Do I feel like sub-Q data is enough for most of our patients? I don't think that's the case, but this helps us build the case for more effective therapies for that patient population. So I'm not sure what happened here. Maybe that was my cue to be quiet. Things along to Dr. Krishnan.
No, I think we were just fixing the screen here. So thank you, Saad, for that.
So bottom line, I think yes, we need to treat. I think we are, I would love to hear the reasons from Dr. Krishnan why we don't need to treat.
And just before we go to you, Amrita, just for clarity, just because we're trying something a little different tonight by not using slides, and so some people may have some questions, I'm just going to clarify two quick things. One, thank you, Saad, so much for giving us your perspective, and I'm excited to hear the outcomes of that smoldering meeting, because I know it literally was hot off the press because it just happened. Dr. Usmani referenced two things. One was the 2020 criteria, which means that someone has the M spike, that abnormal protein that we measure in the blood, of 2 or higher. That if someone has that, that's one potential risk factor. Number two was the 20, meaning there was more than 20% plasma cells in the bone marrow. And number three was in those light chains that we measure, because you remember the myeloma protein is both a heavy chain and a light chain. The heavy chain, as it were, is what we measured with that M spike, that we said if it's over 2, it's a risk factor. But we also measure the light chains, and you have two kinds of light chains: the kappa chain and the light chain and the lambda light chain. And whichever is involved over the uninvolved one, because one of them tends to be high in myeloma because that's what cancer is. It's identical, uncontrolled growth. One of the two is higher, that we can generate a ratio of the kappa over the lambda or the lambda over the kappa. And if that's more than 20, that's a risk factor. So you've got M spike over 2, plasma cells in the bone marrow over 20%, or a light chain ratio over 20. If someone has 2 out of those 3, any 2 out of those 3, that's considered high risk, where people's myeloma, we expect, could actually become active myeloma. The smoldering no longer smolders, becomes active, at least around 50% of those patients in the next 2 years. So when we refer to the 2220 or 22020, whatever way the number is shared, that's what we're referring to. And then number two, the second thing that Saad mentioned was the Aquila trial, which we've described before, and some of you have seen some of the videos we made, which was we took those patients, not just the 22020, but a few other criteria to capture patients who we think were at risk of developing high risk or developing of active myeloma. They were either watched closely, which is what we typically do, or they were given Darzalex, daratumumab, that drug that we often use in combination, but actually just the drug by itself, one single agent, as we call it, one drug over 3 years. And as Dr. Usmani noted, there was a real difference. Those patients that had the Darzalex stayed away from myeloma for longer and may have even affected their overall survival. But not everybody believes that every high-risk smoldering myeloma patient should receive that Darzalex or that daratumumab, and that's what Dr. Krishnan is going to share with us. So, AK, we'll turn it to you, and then we'll have a discussion of all three of us at the end.
All right. Thanks, Joe. So, I think it's obviously still a very controversial topic, and I was asked to pick one side, but nothing is ever black and white, right? So, but having said that, we have to pick a side. So on the no side, I think there's several things. First, and I'll kind of go through them one by one. Number one, risk of overtreatment. Second thing is toxicity of treatment. Third thing is drug resistance. Fourth thing is quality of life. And that also includes financial burden, as well as just risks and quality of life impacts from the therapies. So I guess first in terms of risk of overtreatment, it's really kind of what Saad said, the 2220, is a clinically defined criteria. It's not a biologically defined criteria for really what is smoldering myeloma, right? So I think, and you could argue that you already classified by in the work you did in the, in terms of reclassifying with slim crab, really high risk smoldering myeloma already. So, to me, that's the first part. The second part is if you then just use this quote unquote clinically defined criteria, look at the iStop study, which certainly obviously the IMF was a big part of. That was the study in Iceland looking at the, you tell me, Joe, it's the majority of the Iceland population. 0.53% of individuals over the age of 40, by that clinically defined definition, would have smoldering myeloma. So are we going to treat 0.53% of the US population over the age of 40? And obviously we're a very different population than Iceland, but nonetheless, it's you have to be practical in terms of the scope of the problem. The next thing is in terms of, the prediction models are still impractical, right? So Saad mentioned 2220. I'd be interested from the recent meeting to have we come up with a consensus on what's the best risk model? Because if you look at the Aquila study, how they defined high risk was really not the way most of us define high risk. So, it even becomes harder then to extrapolate the data from that study of daratumumab versus observation, and you have to ask, is it only if I use the criteria outlined in Aquila to define high risk? Then the fourth and probably last thing is obviously the reason you treat smoldering is you want to prevent bad things from happening. And the real question is, did you do that with early intervention of daratumumab? I'm really not going to focus on lenalidomide. I think most of us have moved beyond that. And really, it's the question of daratumumab or not. And so in the Aquila trial, it was daratumumab versus observation, and to progression to myeloma events was the endpoint of the study. And actually, 16% of patients who got daratumumab had progression to bony events versus 19% in the observation arm. And if you drill down even more, it really, very few of those bone events were actual fractures. They were found on imaging. So the real progression events that were prevented from the Aquila trial was anemia. So only 3% of patients treated with daratumumab developed anemia versus 14% in observation. So again, have you really prevented what you really want to prevent, right? Bone disease and renal disease. Not really from that early intervention. So I think for all those reasons, we're still not ready to treat everyone with smoldering myeloma.
Okay, so you've heard from both sides here, and we'll bring all three pictures up here. We'll have a little bit of a discussion around it. So let me throw this in there to help people capture this if some of this has been hard to fully appreciate and understand. I sometimes use this analogy when I talk to patients about smoldering myeloma. I'm a runner. I really like running, and I know that Saad's a runner too. He runs marathons, and I really like running. Just near my house here is a set of mountains, the McDowell Mountain Range, as we call it, as I live in Scottsdale, Arizona. And if I'm running, and unfortunately I'm getting a little bit too close to the cliff, hopefully Saad, who's I'm sure running much faster than I am, would see me getting too close to the cliff and he'd catch me before I fall over. And what am I talking about? We used to say in myeloma, you didn't have myeloma until literally you fell off the cliff, like you had damage to your kidney, you had damage to your bone. The CRAB criteria that Dr. Krishnan mentioned. CRAB, of course, is an acronym, CRAB. Calcium being high, renal or kidney damage, anemia, or bone disease. And so we used to say, listen, I can still hear Dr. Gertz at Mayo Clinic saying to me, show me the CRAB. Like, where is the CRAB in this patient? They don't have myeloma until something is broken. But back 11 years ago now, we changed the definition, so-called slim crab criteria. And the way my analogy works, you guys can correct me if you think I'm wrong, is now basically we've drawn a line, let's say 50 feet short of the cliff. We've said you're getting so close to the cliff that we better stop you from running because you might fall over the cliff and cause damage. But it's not a perfect line, because sometimes crazy people like me love to run alongside the cliff, right? They'll never actually fall off the cliff to get close to it. Other people are running so fast that even if you draw a line at 50 feet, you're not going to be able to catch them in time. The biology of running is different than drawing artificial lines. And the question that we're asking tonight is, if you're 55 feet, 60 feet, 75 feet away from that line, should we be from the cliff? Should we be treating them, yes or no? And this clinical trial said, what if we just give them kind of baby treatment, just a single drug? We've done other clinical trials. The IMF led the ASCENT trial, where we actually gave them a whole quadruplet of treatment, and both are being explored. But Saad is telling us maybe we should stop that person from running even before they get to the 50 feet mark. Amrita is saying, well, let me wait to see that they're proving that they're getting close to the cliff. So I don't know if that analogy helps at all, but that's part of the debate and the discussion. Saad, do you have a comment?
Yeah, a couple of comments, Joe, and kind of building on what you've said and some of the things that Amrita has highlighted. So, for the longest time, some of these clinical trials that were done in quote unquote smoldering myeloma, the risk stratification of whether you're at a high chance of going to active myeloma requiring treatment or a low chance, there were many different ways in which this was looked at. Some groups like the Spanish myeloma group looked at the number of good guys versus bad guys on a bone marrow aspirate to determine whether someone is at a higher chance of going to active myeloma versus not, and that was utilized as a criteria. In other ways, it was looked at by whether someone has an IgA kind of M spike versus IgG. Then people looked at different ratios of the good versus bad light chains, as well as different percentages of plasma cells. So the quote unquote dilemma really came from which criteria do we pick, and that's one of the critiques of not just the Aquila trial that we looked at two or three different types of smoldering myeloma, criteria, and included those patients, but the two other studies with lenalidomide that had been reported in the past suffered from the same critique. Now, the second point I want to highlight is the iStop-MM clinical trial, and who are we really calling high-risk smoldering myelomas? So this iStop-MM clinical trial, this study, the screening trial was done in the whole population of Iceland. It was offered to around, I think 160 or 70K patients. Eventually, a little over 75,000 were actually screened. And Amrita, do you know the number of patients who were diagnosed with smoldering? And the screening was done with very specialized protein analyses with mass spectrometry, which can look at very low levels of proteins in the serum. So MGUS, you're absolutely right. MGUS was discovered in a high proportion of patients, but smoldering myeloma was discovered in only 190 patients out of the 75,000. And of those smoldering myeloma patients, about a third were high risk smoldering. So we're really talking about a very small population out of the whole population who is going to get diagnosed with high risk smoldering myeloma, and that's the population that we're talking about. That's why it's also been challenging to do a clinical trial in those patients, I think, and there was heterogeneity, in the inclusion criteria. So, it's controversial topic, but it's probably going to be applicable to a smaller pool of patients in the clinical practice, I feel.
So maybe to wrap up our discussion around this, let's try to be very practical at the end. So the idea here is, do we treat what's almost myeloma with a little bit of treatment, potentially delaying it, maybe even never getting it, versus saying let's wait and watch a little bit longer as we better define the disease? I'm going to ask both of you the same question. Who in clinic tomorrow with high-risk smoldering myeloma would you really think about treating, and how do you approach that treatment with them? Amrita, do you want to go first?
Sure. I guess I always like Tom Martin's analogy that smoldering myeloma is a movie, right? So I never, from the first time I see someone in clinic, absolutely commit unless I have a few decision points, right? Ideally, they've had sort of at least a couple of values that I can look back at to see a trend. So I think that for me is probably the most important thing. And if there is a trend that's fairly aggressive in conjunction with certainly the defined features of high risk, and frankly, for me, the genomics is what pushes it more. If they have high risk chromosomal changes, I think that's probably going to trump everything ultimately. And I do think, as I said, it is reasonable to have a discussion about treating someone with daratumumab. Now, having said that, there's some people who are so close to actual myeloma, it's really not the question of treat or not treat. It's the question of treat as active myeloma or treat as smoldering. And that's, I think, probably the more important point, quite frankly.
So first point I take from you is let's make sure we know how fast they're running, as it were, the movie that Tom described, that sometimes if I see someone moving really quickly, they're getting so close, they probably need full treatment. And the second thing I heard from you was the importance of the discussion with the patient, right? That concept of shared decision making. That there are some patients, I can think of a patient I had in clinic not long ago who said, look, doc, I'm kind of living my best life now. I'm in my late 70s. I've retired. I'm playing with my grandchildren. I'm doing these different things. If you tell me that you're going to give me this single drug and it's going to keep my disease away probably for a long time and maybe indefinitely, I like this idea. I can handle, an injection once a month, initially maybe every week for a while, but I'm good with that. As opposed to a patient who might say, I think I'd rather just keep waiting and watching and we can decide later. I think the importance of having a conversation with the patient to match what their interests are, what their lifestyle is important. Saad, same question to you. Who in New York tomorrow are you going to meet with in clinic and think that they may require treatment for their high-risk smoldering?
Yeah, so I would echo what Amrita said. One-time values don't help us in that decision making. We have to see what the timeline and journey looks like for those numbers. I have to say these discussions are going to be different for someone who's 75 years old compared to someone who's 45 years old. And Amrita actually made a very nice point about over-treatment, in some of these patients. I would worry about under-treatment in someone who's presenting with smoldering myeloma and has quote-unquote high-risk smoldering myeloma. I would worry about under-treating them with dara if they're young, and would actually watch them potentially to treat them right at the cusp of going into active myeloma with real definitive, myeloma treatment. I would say that patients who are probably in their 70s, I'm going to have a discussion about potentially, single agent daratumumab as they might benefit from it. But my practice may not change for the younger high-risk smoldering myeloma patients.
Wonderful. Well, thank you both for that. I know that this is a little bit different way of having a discussion. We're so used to always showing slides and so on, and I know it may be hard to follow just the discussion, but maybe we'll leave this topic with a few take-home messages for the patients and their partners and their families who are listening today. If you have smoldering multiple myeloma, talk to your doctor about what kind of smoldering myeloma is it. Is it high risk? We sometimes call it standard or low risk, and there's sometimes even something called intermediate risk. People look at it differently, but just have the conversation to know what your numbers are, to know a little bit about that 2020 criteria that we've talked about, because I think it's important for people to know. And then number two, have a conversation with them about whether or not you should or should not be treated. Because as you can hear from the discussion, I'm calling it a discussion, not a debate, because you were way too nice to each other. But because of the discussion that, we do have legitimate options. Some people might want to wait. Some people might want to treat. Some people may want some more information before they make that final decision and wait and watch a little bit longer. And so I think that's important. And the last point I would make is that it just reminds us that myeloma is complicated. It's hard to have a simple answer to everything. And sadly, some patients run very quickly with myeloma in the analogy that I gave, and their disease becomes very active very quickly, and we don't want to miss it. At the same time, we have some disease that moves so slowly that people will go their whole lives without having any treatment and will do really well. And so making sure that you're informed about your numbers, you're informed about your situation, that you have an open, honest conversation with your healthcare team, I think is maybe the most important thing we can leave with you tonight. I will also remind people to keep sending in your questions. My goodness, we are now over 40 questions already asked. So I'm going to move us into topic number 2 so that we can cover our 3 topics. And then that way we can move into the Q&A at the end. And so topic number 2, as hopefully you can see from your screen right now, is asking, can we move that ahead? Oh, yeah. So now we're talking about MRD guidance, and should it guide our decisions both for going to transplant and for what we're being treated with for maintenance therapy. So let me quickly introduce the topic, and then we'll have Dr. Usmani tell us that MRD is the most beautiful thing that's ever happened to the myeloma community. What is MRD? MRD stands for minimal, or sometimes people use the word measurable, but let's call it minimal residual disease. This basically means that we look for tiny amounts of myeloma left in the bone marrow, typically, after someone has been treated and the usual measures of the myeloma are gone. As we've often taught through many of our seminars, when you have myeloma, we follow typically either the M spike or the light chain, one of the elements of that bad protein that the myeloma cells make. And so hopefully you've learned over time that we watch that M spike go down. We watch that light chain level go down. The M spike, we want it to go to 0. The light chain, we go down to a normal level. And when that disease gets all the way down, we know the disease is not cured, but we want to really make sure that it's gone. And we made reference earlier to Dr. Durie. He had committed so much of his life to understanding MRD and what it means. And the idea here was to really look in the bone marrow tests that we do. Can we find one myeloma cell in 1 million cells, and maybe even 10 million cells? That's not a lot of myeloma, but even that little bit of myeloma can grow back. And sometimes, as I say, sometimes in my clinic, Rambo is the last soldier to be killed. The last thing you want to do is knock off most of myeloma, but leave Rambo and let Rambo grow into a very big myeloma. And so MRD testing is when we typically do a bone marrow test to look for that tiny little bit of myeloma that's left. Now that we have such great treatments of myeloma, when I started in myeloma, and Dr. Krishnan and Dr. Usmani started myeloma, we didn't really talk about MRD because we rarely got our patient's disease all the way down to nothing. But now that we can get it all the way down to almost nothing, we want to use this test to help us make decisions. Because when someone has a really deep response, it'd be nice to not get so much treatment. It'd be nice to not have to have certain kinds of chemotherapy. And so there has been some emerging evidence telling us that, well, if your patient gets to MRD negativity, meaning we can't find that one cell in 10 million or 1 million, maybe we can not treat as much. And the 2 areas we've often talked about is transplant and maintenance. What do we mean about transplant? There was a very important French study just done that took patients and gave them their initial, what we call induction treatment to induce a remission or get the disease down. And if they were MRD negative, they decided to do one of 2 things. They were randomized between either getting a transplant or not getting a transplant. And it looks like from the preliminary evidence, and I'm not trying to give your talks on, the preliminary evidence that maybe being MRD negative doesn't require you to go to transplant. We have other studies that have said, well, you're on maintenance Revlimid or lenalidomide, or you're on maintenance daratumumab and lenalidomide. Maybe if you get to MRD negativity, we can stop the treatment instead of having to give people years and years of Revlimid. So the question at hand tonight is, do you use MRD testing to tell people that they maybe don't need a transplant or that they can stop their maintenance therapy? Hence the debate, hence the controversy. Some people will do it. Some will say, no, you need a transplant. No, you need to stay on maintenance therapy. That's what Dr. Krishnan says. But Dr. Usmani says, yes, maybe you can stop having to go to transplant or stop your maintenance therapy. So Saad, now that with that introduction, you fill us in how you approach it in your clinic and what you tell patients about MRD.
No, thank you so much, Joe. And this is a really good topic for discussion because we're still in a fact-finding mode, but I think we're getting some clues to where we need to go, and when we talk about this MRD discussion, we have to also put a preface to this discussion that one size never fits all, and we also have to take into account disease biology. With that being said, I think the main crux of where the field is going is how can we limit the duration of treatment for our myeloma patients now that we are getting uh, such therapies that can take myeloma to undetectable levels in many of our patients, especially for the standard risk patients. And with this in mind, I think the clinical trial that Dr. McHale was referring to, Joe was referring to, was the MIDAS study, where it has many arms, but the idea of this trial was, if patients get to a really deep response, do we need to consolidate patients, or can we just move on to maintenance treatment and still get them the same bang for the buck? So the first part of the clinical trial was reported, and it did show that for patients who get to MRD negativity after 6 months of induction treatment, you may not need the transplant to deepen their response. Those patients can potentially go on maintenance treatment. What we don't know about that is whether the disease will stay away for the same period of time or not, and that's the progression-free survival part. And that's the information that we don't have. So, if I'm seeing a patient today, um, and they're in their late 60s or early 70s, and they're getting a quadruplet induction treatment, and they're getting to MRD negativity at a very deep level, say one out, no, less than 1 in a million bone marrow aspirate cells. Then I'm going to have that discussion that maybe we can just collect the stem cells and put them away, and you don't need to go into this stem cell transplant right away. This is something that can be employed later. I would have that for discussion for standard risk patients, not for high risk patients. But if they're still positive, then I would encourage them to get a stem cell transplant, and then move on to maintenance treatment. The second part to this is the maintenance discontinuation. Joe, do you want me to address that as well, or just?
Sure, yeah, do it. Absolutely.
Okay, all right. So the maintenance part actually is more interesting. I think for standard risk patients who have had more than 2 years of MRD negativity, we actually did a study here. My colleague, Dr. Neha Corday, actually did a study with lenalidomide maintenance, and she found that if you discontinue len in patients who have achieved MRD negativity and have had sustained MRD negativity for beyond 3 years, then stopping maintenance treatment, very few patients actually come out of that MRD negativity to MRD positivity over the next 2-3 years. So I think for standard risk patients, at least in our clinical practice, if patients are getting to that second or third year of MRD negativity, I am comfortable having that discussion. At the end of the day, however, the answer would be gleaned from a study that Dr. Krishnan is actually leading, and I'm sure she's going to talk about that, the SWOG 1803 trial. That one of the key questions that that clinical trial is asking is, can you stop maintenance treatment after 3 years if someone is MRD negative? And I would welcome, comments from Amrita, because, I think you've already finished accrual to that study earlier this year.
Well said, my friend. Excellent, excellent. So if I hear you correctly, you're telling me that for high-risk patients, you're still going to take them to transplant. But for standard risk patients, you might be willing to consider not going to transplant. And that for standard risk patients also who are on maintenance therapy, that there may be a case that MRD can help us stop maintenance therapy so that we can give patients, as I often say, my favorite drug, nada, nothing. Rien. Everybody loves it. Every insurance company covers it. Patients are always 100% adherent to taking nothing. We love giving nothing if we can. If I could write that in a prescription pad, that would be great. Amrita, you're on the more conservative side here, I think, and a little bit more hesitant to give up transplant and give up maintenance therapy. Let's hear your side to it.
So actually, I mean, I think in terms of giving up transplant, we right now have one study really that truly helps us look at that question with MRD, because that study used MRD to make treatment decisions. And I mean, I call it Midas, but I guess the French call it Midas. So we have to call it Midas, right? And I still don't understand that, Joe. You got to explain that to me. But so in that study, patients got a very intense induction therapy. They got 4 drugs: isatuximab, carfilzomib, lenalidomide, and dexamethasone, and for 6 cycles. And then if they were MRD negative, at 10 to the minus 5. So I don't know if you, Joe, if you talked about the sensitivity, right? There are different sensitivities of MRD testing too. And then they were randomized, so half of them were assigned to more of the same intense induction for another 6 cycles, and the other half were assigned to transplant. And they saw, after they looked at that, there wasn't a big difference in the next MRD measurement. So the upgrading and to 10 to the minus 6 wasn't really any different. So really to the question, did you gain a lot more from going to transplant? But what it doesn't tell you is who's going to stay MRD negative with that. So the first point. The second point is everyone's response to therapy can be different. So there's certain groups of patients with certain chromosome changes. For example, patients who have a change called 1114, we know tend to respond more slowly. So if we use Dr. Osmani's thing in a way, he might be actually treating all those patients with transplant, right? Because they may likely not be MRD negative after their initial induction therapy, and they may not even be after the transplant initially. It may take them even longer. So using MRD doesn't take you into account certainly early time points. You don't get a sense of sustained MRD, which is ultimately the most important thing. And you don't get also, you're not able to capture slow responders. And then the third thing with that METIS trial is obviously, but I think we both agree on this, they did not differentiate between high-risk patients and standard risk. Their assumption, I would guess, is basically, well, if you're high risk, you're unlikely to have become MRD negative to be assigned to that treatment arm. But that's a big leap of faith, right? Because we all know there are high risk patients who, in fact, can become MRD negative early on. And I think most of us would still think we want to take them to transplant. Now, the next part of things, discontinuing maintenance, so I actually, there's no way I can argue on the other side for that one, because I agree with Dr. Iswani. I think you need to use MRD to guide that, because, we are in a different era now. We shouldn't be keeping people on even lenalidomide 10, 15 years, right? I mean, you have to ask at that point, what benefit are we really doing to patients? I think the discussion really is around how long do you continue it before you stop it in patients who are MRD negative? Like, what is that sweet spot? And I think, there's some studies suggest 4 years. SWOG was 2 years, right? We don't know the answer yet. So I think in that one, we're really aligned that yes, we do need to stop. It's just at what time point.
Okay, well, so much for being that controversial if you guys are actually going to agree. But no, that's good. So what I'm hearing from the two of you is that the MIDES trial, and that's we pronounce MI en français instead of English, but is telling us, is giving us an important signal. There may be patients who may not need a transplant, but even though MRD is powerful, sustained MRD is even more powerful. And so it may be premature to make decisions quickly. Although I have to say, last week in clinic, I had 3 patients, the nurse practitioner I work with, we couldn't believe. We had literally 3 patients in the exact same scenario. All 3 of them had finished their induction treatment. All 3 of them were MRD negative, and all 3 of them didn't want a transplant. And so we had the conversation. And interestingly, none of them were high risk. One had translocation 1114. So we have to really think through how to have this conversation. But what I'm hearing from you is that you're not immediately stopping all transplants in patients that have achieved MRD negativity. You want a little bit more information. You want a little bit more time. But I think it is at least opening the door that there are going to be some patients who it may sway you against transplant compared to the high-risk patient or the patient with a lot of disease where you're more pushed towards transplant. I'm also hearing from you on the maintenance side that if someone is MRD negative and they're not high risk, somewhere around that 3 to 4 year mark, you're comfortable stopping maintenance. Am I putting words in your mouth, both of you, or do you agree with that? Saad, does that sit well with you if that's what we're telling patients tonight?
Yeah, I think you've summarized things, very well, Joe. And so much for the controversy here. When
That's
you
okay.
have
if we come home with some take-home messages, because there are people who feel very strongly that transplant is. I said on one of our IMF videos once, I said, I wouldn't be buying transplant stock right now as sort of a joke. And 2 patients came into the clinic last week saying, I heard you say that. So I have to be careful what I say when it comes to these controversial topics. But some people really believe that the future of myeloma is not to do with transplants. And so this is just more evidence for them to push it away. But then it sounds like most of us are still seeing a role for transplant until it's really unequivocally been replaced.
All right, but here's the question then. If we're saying that because we don't think it's a curative therapy, right? What if you could do CAR T up front and think about if that is a curative approach? Would you change your answer then?
Well, you're stealing next year's topic.
Yeah, so I was going to say, that sometimes it's always a good idea to kind of, go back and look at these phases of treatment and why they were put in place to begin with. And, the reason why high-dose melphalan was chosen as a consolidation was because it was our best single agent with stem cell rescue. And I don't think we can no longer say that it's our best, single agent. We have much more effective single agent therapies for the more advanced relapse patients that are now coming into the early lines of treatment. So I think the consolidation part will likely be with these novel immune therapies in the future, including CAR T, maybe even bispecifics or bispecific combinations. So I think the field is changing and evolving, and so I do feel that high dose melphalan or transplant will likely go away from the frontline treatment in the near future. And I'm saying this with a very US centric view because guess what? Transplant is still such a valuable component of treatment for the rest of the world. And many parts of the world do not have the kind of access to therapies that we have. So yes, when we were talking about US, yes, Amrita, I'm going to be in favor of getting frontline CAR T cell therapies or immune therapies in the future in place of transplant. Um, but the global reality may be very different. And Joe, you've seen this, so maybe you
Oh
can.
no, I mean, we just hosted our first Latin America Myeloma Network Masterclass and Summit in Santiago de Chile this weekend. So we had this exact discussion that transplant still plays a role, especially when there are limited options in other places. Well, I think this was a great discussion, and I'm thankful, and I hope again the take-home message for patients today is as follows: that we can't think of MRD as being the magic. I have some patients who come in a clinic and they're saying, oh, I watched a video and we have to get to MRD. It's sort of MRD or bust. It's not always the case. It's not perfect test. We also heard that sometimes we need to have it sustained over a period of time. But that being said, it is a parameter that we're starting to use to help make decisions around treatment. And so as you're being tested, as your bone marrows are being done, and I know we try to limit as many marrows as we can do, and part of the research we do at the IMF is to find ways to do MRD testing without having to do a bone marrow. That would be lovely with time. But I think it is important as you're making a decision about transplant, or is it you're making a decision about staying on or going off maintenance therapy, that now MRD is starting to influence some of those discussions as we go forward. All right, I think we have, if we can pull up, I know the slides are a little bit out of sync. If we can pull up the third and final question, and I'm thinking because of our time as it is right now, that maybe what we will do is we will go to our CAR T question and address it, take a little bit of a break, and then work through these now 69 questions that have been submitted. We won't be able to get to all 69 of them, but I promise you we'll do a bit of a rapid fire approach to it so that we can answer the questions as quickly as possible so that patients can benefit from them. So the next topic that we have is CAR T cell therapy. As we've already heard, we know that this is a new and amazing therapy that we have for multiple myeloma. Very quickly, CAR T cell therapy is where we take T cells, which you can think of as soldier cells. We take T cells out of a patient and we basically train them to fight their myeloma. We stick a receptor on the outside, and that's what CAR stands for, chimeric antigen receptor. So the cell has this receptor, this kind of homing mechanism that is just aching to find multiple myeloma based on what that receptor is going to hook onto. It hooks onto the myeloma cell and then triggers this killing of the cell, because T cells are soldiers and they want to destroy the cells that they're programmed to kill. And so this has really been a revolution in myeloma. I don't think we have ever seen a treatment have this kind of impact that we're seeing in multiple myeloma, where we see initially 70, 80, now over 90% of patients are responding to this treatment. Even when people have been treated with everything, we have seen the response to CAR T cell therapy exceed anything else we've had. And so CAR T cell therapy got approved by the FDA. We have two different CAR Ts, something called ide-cel and something called cilta-cel, called Abecma or Carvykti. And those were initially approved when someone had already had several lines of therapy. I saw one of the questions is asking about lines of therapy, and we'll get to it. But it was approved after someone had had 4 prior lines of therapy. And more recently, they've been approved for earlier lines of therapy, in particular for the Carvykti. Someone really only has to have 1 prior line of therapy, and they're eligible for this CAR T cell therapy. So the controversial question tonight is, well, if CAR T cell therapy is so good, if now CAR T cell therapy is available as soon as first relapse, shouldn't we just treat everybody as much as we can possibly get to the centers where we do CAR T? Shouldn't we treat everybody with CAR T cell therapy at first relapse? And Dr. Smani in a moment is going to walk us through the yes answer. Dr. Krishnan is going to be on the no side of it. But the concept here is, should we be introducing this treatment as early as possible in the treatment course, as early as first relapse? So, Saad, I'll pass the microphone to you, a virtual microphone to you, and you talk to us about how we should be using CAR T cell therapy in that first relapse.
No, thank you so much, Joe. And thank you for summarizing, how the CAR T cell therapies work and the two CAR Ts that we have in our armamentarium right now. I do want to, give some editorial comments about both the products as well. So, Cilta-cel is the product that's currently approved for patients who are relapsing for the first time, and they may have had exposure to proteasome inhibitors and immunomodulatory drugs such as lenalidomide, as well as anti-CD38 monoclonal antibodies such as daratumumab or isatuximab, but they have to be progressing on lenalidomide, so they have to be refractory to it to qualify for Cilta-cel at the time of first relapse. And many of our patients are on lenalidomide maintenance, who would if they're progressing, they would qualify for CAR T cell therapy. And the way that I would say this is, if we were in utopia and we had infinite supply of Cilta-cel products, and we could deliver them in a safe way to patients, absolutely. I think giving a treatment that can put patients in a very deep remission at the time of first relapse, and no complication whatsoever, then yes, I would give it to my patients. Right now, the patients that I'm really aiming for at that first relapse to get Cilta-cel are the patients who are relapsing sooner than we expected, or have high risk features. And the reason why I say that is going back to all the wonderful discussion we had for the previous two questions. We have very effective 4-drug induction treatments with or without transplant. We can give deep remissions to patients. And if we start looking at patients who are progressing after getting that initial treatment, it's maybe 1 to 2 out of 10 patients. So it's not a big proportion of patients in that first 2 or 3 years who would go in that category. So yes, if I had my way and I could give them the best possible treatment at that first relapse, it would be CAR T. And I'm sure Dr. Krishnan will talk about the reasons not, and we'll talk a little bit about the side effects and some of the concerns that I do have, but maybe Amrita can elaborate on that too.
So Saad, you're telling us basically what I've often said: don't save the best for last.
Yep.
If you've got something that works and even more effectively, let's use it as soon as possible. So Amrita, then why shouldn't we be using CAR T for everybody at first relapse?
Well, I think Saad already touched upon it. He as he said, he's not going to do it for everyone because of the risk of toxicity in certain patients. And of course, the toxicities, the short-term toxicities in terms of low blood counts, can last for up to 6 months, up to 20%. So it's 1 in 5 patients we've been giving stem cell boosts to after CAR T to help their blood counts. Now, that may be mostly because a lot of the CAR Ts we're doing are people in more advanced disease. So possibly if you do it in patients who are at first relapse, they probably have healthier bone marrow, so that may be less of an issue. There is a short-term risk of, their infections that certainly spikes up, but it's really more the long-term risks, right? For certainly the neurologic toxicity, it's become much better. You kind of use about 1% as a figure for delayed neurologic toxicity. The problem is that's still a complication that we're not very good at treating. We have a lot of measures that we try to do during the CAR T cell therapy to try and mitigate those risks, but even those are controversial if they really are doing anything. And there are new toxicities that we're learning about. And here we have even less knowledge, quite frankly. There's something called IEC colitis, which we know is a very, what's the word, life-threatening complication of CAR T cells. And we still don't really have a true feeling about the incidence of that. I've seen some centers and some sort of single center publications suggesting between 10 to 16% of patients can get this IEC colitis. Now, we don't have a good real definition of that yet. We don't have a good sense of what are the risk factors for that yet. And we don't really have a agreed upon algorithm for treatment. Hopefully there are things that help treating it, so basically what I'm saying is there are risks with CAR T that are still, what's the word? You do it and you still have these potential risks that you still don't have a good handle on what is the chance of this individual patient sitting in front of you of being that 1% or that 16%, right? And so that's where it's a little bit more of an issue. I think with traditional chemo, we're very comfortable, not because we say there's no risk, but in that setting, we are able to basically reverse those toxicities for the most part pretty quickly. And most of those toxicities are not going to be life-threatening. For example, someone, if they at first relapse, you put them on daratumumab, pomalidomide, and Decadron, the low blood counts, probably not a big deal. You're going to reduce the pomalidomide, right? An infection, most of them are respiratory infections with daratumumab. You're going to give IVIG, you're going to treat the respiratory infection, maybe you're going to hold the daratumumab. So it's a little bit less of, concerns for us. We find those toxicities manageable. There are also, of course, risks of second malignancies. Again, here we don't have we have some idea of risk factors, but probably that's not the whole story. So I think for me, it's more the unknown when you sit with an individual patient in front of you. Are you going to be the one who gets this? You can, again, it's not 1% if it's you, it's 100%, right? And that's the problem. The last part of that, I would say, is the fact that just like everything we do, like your old iPhone to where we are now, right? Things get better. And so CAR T is getting better and better as well. That's both in terms of the manufacturing time, we can shorten that, but even more in terms of the toxicities. Hopefully there's some CAR T cells out there that seem to have, so far at least, reported no long-term neurologic toxicities. Now, whether that's just because they're still too new and we may see it, maybe, but we're still waiting to see. And then maybe even those will have even longer efficacy. So, it's also a question of maybe I don't know if, Joe, are you first in line at the Apple store? Or are you like, this looks good enough and I'll wait, right?
Yeah, I can't say I'm always in first in line in the Apple store because I don't want to stand in the line forever. But I think you make really, really good points, and both of you always do, of course, and I appreciate it. I know it's a lot to take in for our patient population tonight, but let's think about what we've learned. We've learned that CAR T is potentially the most effective therapy we've ever had in myeloma, even the older iPhone, according to Amrita's example, right? It's pretty impressive what it does. And again, I have no conflicts with iPhones, but I'm just using your analogy. But at the same time, there is a concern about certain side effects. And I have to say, adding my 2 cents here, on the one hand, I have so many patients that are alive today because of CAR T. And I'm so grateful for it. And I think we want to use this modality every day in clinic because it has transformed people's lives. but we just also have to remember that every treatment comes with a risk. And I'm thankful that as we look to the future, those risks are going to be minimized. One, because we're learning how to use these treatments more safely. You know, the IMF has created the immune therapy registry where we're capturing this kind of information from multiple centers from all over the world so that we can learn faster. If it's a side effect that only happens in 1% of patients, you're only going to see it once every 100 patients. But if we pool our information together, we can get the answers more quickly. And that's why I think the IMF is so committed to getting those answers more quickly. But we want to minimize those side effects now by using the drugs we have better. But also, as you said, Amrita, the future is exciting. When I look at a couple of weeks from now, when we're going to be at ASH, some of these newer CAR Ts that seem to have even fewer side effects. You know, as we build newer cars, they move faster, they move more effectively, and they use less gas. They may be even electric cars. So I really think that there is a lot to come in the future. But for patients who are being treated right now, the last take-home message is the importance of having this conversation with your doctor, because it may very well be something that would work. That would work very well for you, that is ideal at first relapse or at second relapse. Or it may be a situation where looking at the different choices, you may choose not to have it. But if I'm going to be a prophet for a moment, I think we're going to see a whole lot more CAR T in myeloma in the future, because I really think it gives us an opportunity to treat more effectively. And one of my favorite parts of CAR T is being able to put people again back onto nada, because in general, we're giving people no maintenance therapy after CAR T. And so many of our patients are able to go off of all treatment, and it really helps restore much of that quality of life. Nonetheless, I think we had a really great conversation about different controversies, smoldering myeloma, MRD testing, and CAR T cell therapy, which are really important parts of what we do in multiple myeloma. Well, believe it or not, we've received over 100 questions. I am not going to guarantee that we're going to get through them all, but here is my plan. We have about an hour. I think we'll take about another hour to answer as many of these questions as we can. Some of them I'll answer quickly. Some of them I'll turn to Dr. Krishnan or Dr. Usmani. But it really makes my heart happy to know that people are asking us questions. We want to provide as much answer and as many answers as possible to them. I'll just put another plug in that if for the questions that we don't get to, and in general at the IMF, we want to be here to answer your questions. Use our chat bot, use the info line, use the hashtag #AskTheIMF on any social media channel. We keep record of all of these questions, and then we try to answer them in live programs like this. We do Facebook Lives. We do multiple videos on a regular basis. We do our very best to try and answer those questions as we help you as you're guided through this process and have your conversations with the healthcare team where your decisions are made for your treatment. All right, Amrita, Saad, lock and load. Here we go. Any treatments recommended for intermediate risk smoldering myeloma? Saad.
No, just observation closely with blood work and seeing your physician maybe once or twice a year.
Excellent. I think you make the critical point is that we don't want to overtreat too early. That's why we stratify into high risk smoldering myeloma versus intermediate risk. Question 2, is there any research supporting the treatment approach to start CAR T cell therapy even sooner, Amrita? You made reference briefly to them in your comments before, but maybe just make a quick comment about some of these frontline CAR T therapies.
So there's 2 trials. There's CARTITUDE-5, which is basically RVD versus CAR T, and patients not intended for a transplant. And then there is CARTITUDE-6, which is DARA-RVD, so 4 drugs, and then half the patients getting CAR T, the other half getting transplant. And both trials have completed accrual. The non-transplant trial probably will read out earlier, but the one we really want to know is really the transplant versus CAR T up front.
Okay, so stay tuned to more of our workshops going forward. And as soon as this data is available, we'll make it available to you. And I should just add, to be very careful, we do our best to answer questions and support you through your journey. But remember, we're not your treating physician, although I know sometimes we get notes saying, "Hi, Dr. Joe, I'm your patient." But we're not here to replace the conversation you have with your healthcare team. We're here, as I've often said, I love the way how Susie used to teach us to say, we're not asking you to question your doctor. We're preparing you to ask the right questions of your doctor. So please note here that we're not replacing your treating team here.
And I think, Joe, I forgot to add too, just to my point that, this is only the future cards coming up. So there are phase 1 trials, and I think Dr. Zmani is participating in that one as well. For example, with a CAR T that is targeting BCMA and CD19, and that's for high-risk newly diagnosed myeloma patients. So there are actually quite a few there's a big interest in that upfront space.
Absolutely. Beautifully said. So if someone is MRD negative 2 years after transplant, what would the treatment be if they're high-risk 1Q gain myeloma? Do you give Revlimid for 2 years, for 3 years, for 5 years, or just indefinitely? Would you add something else to it? I think I'll take this one. I mean, the reality is we don't fully know the answer yet, and we're still trying to understand it. Even though we, just like when we talked about the smoldering myeloma discussion, we put people into a high-risk bucket, into a standard risk bucket. It's not always perfect. And I think this requires a good conversation with your treating provider. In general, when people have what we now document as high-risk myeloma, and we've had a relatively new update to how we define high-risk myeloma, if someone is tolerating the therapy well, we typically will want to continue it. Most would say at least for 5 years, but perhaps even longer, depending on the scenario. If someone has gone on maintenance Revlimid for 5 years and their disease hasn't come back, they're not really behaving, as it were, like high risk. So it may be worth having a consideration. But we want to balance someone's quality of life of being on drug with keeping the disease down for longer. I think going in the future, we're going to be using more drugs like in the question here, isatuximab added to Revlimid. But at this point, we don't have the perfect answer. I think we will use MRD to help guide us, but in that high risk scenario, we're more conservative about stopping treatment. Here's a good question for you, Saad. Why do so many of the newer treatments and trials require so many prior lines of therapy? I'm newly diagnosed. I had 4 cycles of induction with 4-drug regimen. I feel like I'm missing out and being excluded from some of these treatments because they're only available after multiple lines of therapy.
No, that's a great question. So, and I'm going to quickly, there is no short answer for this. So I'm going to try to explain where, whenever we come across a new treatment that works well in the lab, looking at cancer cell lines or myeloma cells in a petri dish and in animal models. If we see a therapy or a drug or an approach working, we have to first do initial clinical trials to determine if they're going to be safe and effective in patients. And typically that initial evaluation starts in patients who have had other treatments and the myeloma has come back or the cancer has come back. And so, that's how the clinical development of these therapies starts. So after that initial experience of making sure it's safe and that it's effective, it starts its regulatory approval in late myeloma patients, and then we have to do clinical trials to prove that it's going to be better than the available treatments in the earlier lines, and then it comes to the frontline treatment paradigm. And this whole process takes about anywhere from 7 to 10 years. And in myeloma, we've been very lucky that in the last decade, we've had many new treatments that have kind of made their way. So the 4-drug treatment that you're getting, the patient with this particular question, we got to those 4 drugs in that same fashion. We started with 1 drug along with steroids. We proved the point that the second drug works. It got combined, and that's how we came up with triplets. And then the fourth drug, was added in that same fashion. So, you in many ways have benefited from patients who went on those initial clinical trials to get to this point where you can benefit from this four drug combination, and it's the same story with every other drug. So sorry about the long answer, but that's kind of how this
No,
works.
it's a great answer, Saad. It's just so important. I mean, as I often say, safety is paramount. And so when we introduce new drugs, we need to introduce them in a place where as you mentioned, that first of all, we prove that they're safe. But we're living in the golden age of myeloma, where very, very few treatments now are really going to be confined to the late lines, especially as we see the results of these clinical trials. And Rita, here's a question that someone asks, and this comes up quite a bit actually, about osteoporosis. Now, I don't always have the perfect answers for this, but is hormone replacement therapy helpful for bone health? Or is there too much risk if someone is on Revlimid because of the potential for secondary cancers? I'm not comfortable with bisphosphonates, this particular person says, but they have severe osteoporosis. I guess maybe we could even broaden it a bit to say, what is your approach to bone disease if someone does have osteoporosis in the context of their myeloma?
So, I mean, I guess luckily we work with a great group of endocrinologists. I usually send them to endocrine to make those recommendations because, number one, there's more than one osteoporosis drug. Because in this case, when you're assuming the osteoporosis is the bone disease in that case you're talking about is not being driven by myeloma, right? It's been driven by whatever factors cause osteoporosis as you get older, hence the question about hormonal therapy. So first, it's really looking at it as the best treatment for myeloma bone disease is treat the myeloma and certainly bisphosphonates, but assuming the myeloma is in remission, and the osteoporosis question tends to come up, many years later or after, you're in remission, then there is a role for bisphosphonates. There's a role for obviously good supportive care. The black box warning on hormonal therapy has been removed. And, again, that's a discussion with our endocrinologists about the role of hormonal therapy. Hormonal therapy, by the time you have osteoporosis, is not going to reverse that, though, right? So that's really the issue. That's not really the juncture where you're talking about that. You're talking about what are the treatments, and there's another treatment that's not a bisphosphonate. I mean, certainly there's Exgeva as well, which is not a bisphosphonate. It still has some risk. And then there's a third class of drugs, which I'm blanking on now. And if you remember, Saad, that's only used in osteoporosis. It's not and I'm blanking on the name of it.
Teriparatide, or are you talking about recombinant parathormone?
No, it's another one, and I'm blanking again. Do you remember, Joe? If I see the name, I only know the trade name, and
Which is the trade name?
that's what I'm trying to blank on.
Oh, I see. Oh, it's not that you don't. I mean, I know a lot of our patients are receiving Prolia, but
Prolia is
It's a proprietary.
yeah.
Yeah,
So-
but it is teriparatide.
Is it okay?
Yeah. So.
okay, yeah.
It's teriparatide, but it's not used for cancer-related bone loss, to my knowledge. So, but
What's the other name for it, Saad? Because now it's going to sit in my head, right?
So once we're done, I'll probably Google it.
Are you thinking about raloxifene, like Avista? Like, are you thinking for the
Avista, that's it.
receptor
Avista,
modulators?
thank you.
Yeah. So yeah, okay. So now I understand what you mean. Yes.
Okay. Yeah. So
Yeah, so thankfully, the whole field of osteoporosis has come a long way. And what I think is an important point to take out of this question too is that sometimes we attribute everything happening to the bone to be related to myeloma. But I think it was important to remember, maybe even just broadening it further. Myeloma patients are allowed to have other conditions as well. So we always remind our patients, it's important to get your high blood pressure followed up, or your diabetes, or your cancer screening, these other things. Sometimes we can be so occupied with myeloma, but especially when it comes to the bone. So I would reassure that this individual, there are other options other than bisphosphonates for sure. I'll take this one here. What am I going to switch to as my M spike is slowly going up on maintenance, Dara and Revlimid? At what point do I have to start something new? Do I need to get a PET scan or a bone marrow to start a new treatment? This is such a great question and such an important question. A couple of things here. One, this is why we follow patients when they're on maintenance therapy, because typically the numbers change and rise before people feel anything. So we don't want to wait until people feel sick or break a bone or become anemic. We want to follow the number. The absolute number is maybe not as important as the relative number. So we might have someone who has an M spike of 2 who's not getting treated, someone with an M spike of 0.5 who is being treated. So it's the relative change in the M spike that makes a difference. And typically when the disease wakes up, we do, if you will, restage the disease or reanalyze the disease with a bone marrow, often with a PET scan. And then we talk about all the options that are available. And the shared decision-making model is where we say, okay, here are all the options. Let's see what matches your lifestyle, your preference the most. So really good question. And I think it's really important. And that's why we want to empower our patients to know their numbers, to know what the doctor is following when you're being seen in clinic, that light chain level, that M spike level, so we know when to intervene. Another question is there any diet information for patients? Well, again, that's maybe could be one of the controversial topics because you ask 10 myeloma doctors, you'll get 10 different answers. But I mean, the short answer is that there is some kind of connection between our diet, of course, and our health in general and cancer in general. We know that obesity is unfortunately a risk factor for many cancers, and it includes myeloma. I'm actually fascinated at some abstracts being presented in a few weeks at ASH, even looking at the new GLP-1 agonist drugs, these new drugs primarily designed for diabetic patients, and how it may influence progression to myeloma. At Dr. Usmani's site, Dr. Urvi Shah, who's often spoken to us about diet, has spent much of her career trying to understand this, even has the clinical trial, the Nutrivention trial, trying to see that if we have dietary modifications, can it reduce the risk to active myeloma? While we're piecing this all together, we don't have a perfect answer. There is no perfect myeloma diet. I think it's helpful to get insight from a dietitian in general to learn your eating habits and what may be working well, what may not be working well. I do think that weight control and health in general is so important because it will, even if it doesn't directly affect the myeloma, it affects your ability to tolerate the treatments that we have. So I know that's a lot of vague answers, but I do think that we're still trying to understand the dietary information. I reassure people we're doing lots of studies and trials to understand this better. There are clearly some diets that are not good for us. There are others that are showing greater promise, but there isn't a myeloma-specific diet. Here's a question. I'm high risk and have not had a relapse yet. Does my being high risk change either of your opinions on doing CAR T cell therapy at first relapse? It came up a little bit in the discussion, but maybe, Saad, do you want to take that?
Yeah, so sure. So, first of all, I'm really glad that, you're doing well and hope that you continue to remain in a good, response and remission for as long as possible with your first line treatment. If, however, you have a relapse in the future, and I don't know, how old you are, etc. But in general, with high risk patients, we want to give them the best option each line of treatment if they're relapsing. So the answer is yes. At first relapse, cilta-cel would be my most preferred option for someone who has high risk features.
Excellent point. I think we're seeing more and more use of that. On the subject of CAR T, Marita, someone asks, are many of the CAR T cell therapies you describe less effective in patients like myself who have gone through several lines of therapy? I mean, can CAR T be effective even if you've had multiple lines of therapy?
I would say yes. I mean, the CARTITUDE-1 trial, was patients have had a median 5 prior lines of therapy. So it really showed us the response rates are still extremely high. And, even more, I think everyone's familiar with the New York Times article of the long-term remissions we saw in about a third of those patients. So absolutely yes. The one thing I would say, though, is the types of prior therapies you had is really influences that, right? So that we do know that if patients have had bispecific antibody treatment before CAR T, and especially as the immediate treatment before CAR T, it tends to make the outcomes of CAR T less durable. So that's really the one take home I would say.
But I agree with you. I mean, I think without being melodramatic about it, it's worth being excited about the fact that 1/3 of those patients treated with a single infusion of CAR T cell therapy. This is a group of patients who typically, sadly, would not have likely survived much more than a year. We see 1/3 of them 5 years later still have no disease. It's actually caused the myeloma community to have to learn how to define cure. We're not saying these patients have been cured, but we need to start to set guidelines around what cure is because of that. So yes, this was a great question from you, Fred. Thank you from my homeland in Canada. Thank you for asking a question in Canada. Even when patients have had multiple lines of therapy, this can be very effective. I had a stem cell transplant last month. I was also diagnosed as having 1q amplification, or which just means extra copies of 1q that puts someone likely at high risk. Although by itself, we've learned it's not high risk in the new criteria. What do I do when it comes back? Do I treat? And we hope, as Saad mentioned about the other patient, I hope it doesn't come back for a very long time. That's one of the reasons why you've had a transplant, and they'll chat with you about what maintenance therapy to have. But there are more options now than there ever has been, even in patients with 1q amplification, which, as I say, in the new criteria by itself is actually not high risk. It needs to be accompanied by something else. So you may not have the true high risk, although we always say risk is a spectrum. So we have to think about that carefully. But please know that there are many options for you, and those options continue to grow. If the SPEP shows biclonal gammopathy, but the two M spikes are not the same, is that due to one being DARA and the other being myeloma? Well, that's a really good question. Saad, maybe you take that question. I'll let you answer that one.
Yeah, so this is an interesting question. I'm guessing you did not have the biclonal or the two M spikes when you initiated treatment. That's my assumption. But sometimes we can actually see myeloma patients presenting with two different kind of M spike clones. They may belong to the same family. They might be IgG, or IgA, but maybe that they're coming in from two different sister clones that of myeloma cells that a patient may have. In this particular case, it's important to share with you that daratumumab and isatuximab and elotuzumab, these monoclonal antibody treatments, are IgG antibody treatments. So when we do the serum protein electrophoresis test, we can actually see these show up as tiny spikes on that electrophoresis. And so, yes, if you did not have a biclonal M spike, and after initiating treatment with daratumumab, a serum protein electrophoresis and immunofixation was done, one can actually see a tiny spike where DARA, whatever DARA is still floating around in your bloodstream might actually show up as a tiny speck there. And the second part of that question is the mass spectrometry or HydraShift a better test? That test, yes, it can just delineate that daratumumab or monoclonal antibody treatment spike. But guess what? Most pathology colleagues who have been reading these for a while would be actually able to tell you that this is DARA and this is the M spike coming from the myeloma. So they should be able to comment on that.
Great. Excellent. Yeah, that's a really important thing because you want to know your numbers and you want to make sure your numbers are actually the disease itself and not the drug that you're taking. Someone asked, are the slides of this presentation going to be available to the audience? We always make our slides available, although interestingly, we were test piloting something new tonight, and we appreciate your feedback if you thought it was helpful or not to actually not have slides. But for the other slides, of course, we can make them available, but typically we always make our slides available. Here's a patient, Amrita, 45-year-old diagnosed in July, City of Hope. Well, you know something about City of Hope. Deletion 17p, responding well to treatment after 3 cycles, numbers normal. I have the opportunity for a clinical trial to receive new CAR T as first-line therapy instead of stem cell transplant. The CAR T shows no neurotoxicity markers. What would you advise?
Yeah, I mean, I think that's a really, as you said, shared decision-making with your doctor. I think it's really your own risk tolerance about something new, which has promise, but is in the phase 1 setting, which means that we still are trying to study it and understand side effects versus kind of the more conventional tried and true approach. So, I don't think I can advise one versus the other. I can just say, I think it's good to have options, right? And especially in the high risk setting, certainly having, options both in the CAR T side as well as just in terms of, certainly stem cell transplant. Both of those, is, I think are really a discussion with your doctor about which road is best for you.
Excellent. Thank you, Rita, for saying that. It's just so important to have that conversation. Todd, is IgA myeloma by itself a high-risk feature over IgG myeloma? I know in the smoldering world that was part of what was selected in the Aquila study, but even if we just look in general, is IgA by itself a high-risk factor, or only if certain cytogenetic features are accompanying it? This is a great question that says that it looks like they've gotten different opinions from different doctors, and they want to be able to advocate for themselves.
No, I think this is a good question. So back in the day, when we did not have good cytogenetics and fish studies available, etc., IgA was thought to be a more high risk feature. And part of that is because the IgA protein is different in terms of its structure compared to the IgG protein, and the amount of the IgA that's typically secreted by regular immune cells, including plasma cells, tends to be much smaller than the IgG protein. So if someone has an IgA myeloma and their M spike is 1 gram, that does not equate to another patient who might have the same M spike but has the IgG type. So I guess what I'm trying to say is, you can have, one type of myeloma, either IgA or IgM, but the M protein value will not necessarily tell you how much or how many myeloma cells are there in a patient's bone marrow. So, so patients who had IgA myeloma would present with the old-fashioned way and be monitored in the old-fashioned way, and actually have more myeloma, have a higher burden of disease, and that would be potentially the reason why they are not responding as well, or the myeloma is coming back sooner. It was only later on that we figured out, well, it's probably got to do with disease biology. Maybe some of these patients have high risk features. So in today's day and age, IgA on its own is not considered a high risk feature, but back in the day it was, but it was due to different reasons.
Fantastic. Great answer. Yeah, because I know sometimes people come in and ask and they're very nervous just because they have IgA. Someone asked a relatively long question. I won't read the whole of the question, but someone has had myeloma for 4 years already, has been treated well and has been in remission, has been on lenalidomide maintenance for 4 years, and is wondering what's going to happen in the case of relapse, that they could receive various different therapies. But the reason why I'm bringing this question is they say, what do I use to replace the lenalidomide? And I think the point here that's important is that when someone's disease wakes up, we typically stop whatever you're on right then, because the myeloma is growing in the presence, in this case, let's say, of the Revlimid or the lenalidomide maintenance. And so when that's happening, we typically don't just add a drug to lenalidomide. We generally replace it with something else. Because sometimes we can see a scenario where someone, stays on a drug and just the other one gets switched around. And typically we don't recommend that, because the evidence is that really, if a disease is growing while on a certain drug, that drug's not helping very much. And so we want to change that mechanism of action. In the days where we didn't have a lot of choice, we didn't have choice to do that. But now that we have so much more choice, we're typically doing that. Here's a great question. Are there non-bone marrow biopsy dependent tests, for example, blood samples, available for determining MRD status? Saad, just because I know you're interested in the area, I'll let you take this one, then I'll bring the next one to Amrita. But is there hope for people to be able to do MRD testing in the blood instead of having to go to the marrow?
I think it's coming. I have to just share the whole MRD story with you guys. It took us almost 17 odd years to finally get the MRD test validated for regulatory purposes in clinical trials. And that was, it took us 10, 12 years to actually test and validate the MRD test on the bone marrow biopsy. And then it took us another 5 or 6 years to convince the regulatory authorities that we can use this test for clinical trial purposes. And right now, we're in that same phase of testing mass spectrometry in the peripheral blood, looking at cell-free DNA, some circulating tumor cell assays as well. We just have to prove the point that they are equivalent to the bone marrow aspirate test, and we would be able to follow the disease along, for patients. But I think it's still a few years away. If you go to a myeloma center of excellence, we might be able to do that test to help in your research level care. But as standard of care, I think it will take us a few years to get it to you.
Excellent answer. Amrita, I got a whole series of questions here related to smoldering myeloma, and we'll try and cover them together. It was really nice. Someone gave you a shout out and said, it's great that Dr. Krishnan is emphasizing side effects. We want to make sure that we're not just looking at numbers, we're actually looking at side effects. But someone asks, if someone progresses on Aquila, how confident are we to re-challenge them with daratumumab? Or are they daratumumab resistant?
I mean, that's a great question. And that's, I think, what we struggle with, right? Is this question. There was a paper that just came out that, about patients progressing after CD38 antibodies, suggesting that some of them do lose CD38 expression. The question is, what is the true likelihood of that happening? Number one. Number two, there's a difference of progressing while you're actually on the CD38 antibody, right? I think that's a much higher risk type of scenario versus if you've had, for example, Aquila, which is fixed duration of CD38 antibody, and then you progress 2 or 3 years later. I think in that scenario, we'd be very comfortable giving you a CD38 antibody again as part of your treatment.
Yeah, I think you've nailed it. I think the issue, and thankfully, is those patients, unfortunately, that did progress on Aquila, most of them was not while they were getting the daratumumab, but later, and so they wouldn't have been as resistant to it. Is Dr. Usmani in favor of universal screening in the United States of America? Have we reached a point where that could have been one of the other controversial topics? Should we be screening patients with myeloma for myeloma?
So I think that so I'm a proponent for more selective screening or more directed screening rather than the whole population. for us to do screening for the whole population, we actually need to prove the point that it's going to improve the longevity or overall survival for patients, and that's what the breast cancer and colon cancer and even early stage lung cancer screening programs have actually proven that point. The iStop MM clinical study will actually be looking at that question, and if in the next few years it proves that point, then absolutely yes, I think we should be able to extrapolate that and try to implement this here. When I said selective screening, if you have um, one or two relatives who've developed a plasma cell disorder, then I think it's important for you to think about getting screening. I say one if you are of African descent, two if you are of Caucasian descent. But that's just my opinion based on the available evidence we have. Because I do have patients who ask me this question, that should my siblings or my children be screened for this, and that's the advice that I give them, that we don't have any evidence of doing universal screening, but your siblings or your children, as they're getting older, should talk to their physicians about this, and if offered, be tested.
Excellent. Yeah, I think hopefully the iStop study will teach us, and we think we may have the answer within 2 years. The real question is, does screening save lives? And if it does, then we would have to look at ways we're going to implement it.
Yeah.
Wow, still many questions on smoldering myeloma. There's no way we can get to them all, but Amrita, one that came up because you made this comment in your section was, what are the genomic tests or findings that make you concerned in smoldering myeloma? Because remember, we were talking about the 2020 is not perfect, and I understand several people have put in the comments, there may not be the perfect numbers. They don't catch people with light chain only, and I think we all understand that they're not perfect numbers. But which genetic features make you concerned in addition to the 2020?
Well, I think it's the same ones that we look at in active myeloma, really, that suggest you have a more biologically aggressive disease. And of course, number one on that list would be 17p deletion.
Yeah, I agree with you. And I think if we just go back to the same point, there's a dynamic model. A lot of people are asking questions like, well, if I had 2020 and now they think I have anemia, well, then that may, changes things, right? So that's why there are going to be differing opinions, because things do change. And several questions asked, how do we follow it? I think one of the things we learned from the Aquila trial is that it actually probably gave us a follow-up routine that makes sense. I know that I typically follow what was followed in Aquila, which was that people get their blood work every 3 months, so 4 times a year when you have smoldering myeloma, that a PET scan is done either annually or every 2 years, and a bone marrow was done roughly every 2 years. Now, there may be things that make you do it more frequently or less frequently, but that gives us a general guide, because those are the numbers not only that make up to 2020, but that give us a big picture. And just as a reminder, I've often said this, myeloma is like a crime scene. There isn't one piece of evidence that tells you the whole story. Right? That's why we do so many different things. We look at the blood tests, sometimes even the urine tests. We may have to do a bone marrow. We have to do x-rays. We have different kinds of blood tests, the chemistry of the blood, the hemoglobin. All these things together paint a picture. And it's sometimes hard to know with one single measure what the disease is like. We see the change over time.
I think you made a good point too, Joe, about the every 3 months, because the people who are more in the favor of treat rather than observation always make the point that not everyone in observation is getting the observation that was done in Aquila, right? And
Right.
That's I think an important thing to bear in mind, that if you are going to do observation, then you want it to be a pretty structured observation, and with really planned bone imaging, I think, to me, is probably the most important thing.
Indeed. Someone asked really a question. What is the difference between MRD and stringent remission? Now, very quickly, when we talk about response or remission, we typically talk about the depth of the drop of the measure of myeloma. So if you think of myeloma like a tumor, if someone had a lung tumor and it started at 10 centimeters, we would measure it as it shrinks down. And we wanted to get to zero, of course. Well, in a similar way, we have these abnormal blood tests that we follow in myeloma, and we've set different criteria to define. We typically say someone has responded if it's cut in half, because we've learned over time that if you can cut at least the disease in half, that people are going to do better than those who didn't have it cut in half. Now, it's not a magic number, but it's giving us a ballpark. We call that a PR, or partial response. If it goes down by 90%, we call it a VGPR, very good partial response. If it goes down by 100% and pretty much disappears, we say it's a complete response. It's not cure, but it's a complete response. But we have added some riders to complete response. To really be in complete response, we have to repeat the bone marrow and show that there are less than 5% plasma cells in the bone marrow, because that's essentially normal. But then not that long ago, we added a new category of stringent complete response, which paradoxically we may lose again in the near future with our new criteria. But stringent complete response means that when we look at those plasma cells in the bone marrow that are less than 5%, we have actually determined that they are not cancerous plasma cells, but that they are normal plasma cells. So we do some more sophisticated testing on those. And at the same time, people also need a normal light chain level in their blood to meet stringent complete response. MRD is even deeper. MRD says we're looking for 1 in a million or 1 in 10 million cells in that bone marrow. And then we're saying, oh, you're MRD negative because we can't even find one in that 10 million. So MRD is, if you will, going a little bit further than stringent remission.
Can I ask a question, Joe, and maybe to you and Saad? I mean, to my mind, stringent complete remission is sort of should go away as a category now that we have
it. It is going away in the new criteria.
It is going away, yes.
Just because it's been used as just to let the crowd know, we have, it's been 10 years, but we're going to revise the IMWG criteria, or the International Myeloma Working Group criteria, to make some of these subtle changes, and that will be one of them.
All right, I'm going to put you on the spot, Joe, because we've been hearing at every IMWG breakfast for the new criteria, but when is the official drop?
Well, I think it depends on its full publication. Dr. Usmani could comment on it further, but perhaps we could say we are hoping to see them within the next 2 months. Is that fair to say, Dr. Usmani?
Yeah, I think so.
Okay. I know our times go, we're 6:15, but it's good. We've made it into the 50s now, at least in the questions. There's over 120 of them, but I'm trying to lump some of them together to answer some of them together.
I didn't help you when I asked my own questions.
No, it's great. You're allowed to ask questions. You're a speaker. You're allowed to. We've answered some of these already, so I'll skip a few of them. But can a high-risk patient with translocation 414 and 1Q amplification who gets to MRD negativity after 4 cycles of DARA KRD skip the transplant? If I heard both of you correctly in the sort of debate part of this meeting, both of you said if someone has high-risk disease, you would not be comfortable avoiding the transplant even if they're MRD negative. Saad, Amrita, is that a fair statement? You would still want them to go to transplant? Obviously to be discussed with their doctor, but in general, we would want to do that.
Yep.
You addressed this a little bit, Saad, already, but I just want to raise it again because it comes up so many times. Is there a test family members need, I guess, if I am a patient diagnosed with myeloma? And I just want to reiterate what Dr. Usmani said, because it really is so important that we right now do not have simple guidelines that say if you have myeloma, then all your family members should be tested. We don't routinely do that. We don't have that. We know that having family members with myeloma can slightly increase the risk. Most of us feel that if there are 2 direct family members that have, we've had situations, I remember recently a patient had 3 siblings had myeloma, and the 4th sibling came to see me. I mean, I think it's worthy of having at least the conversation. And the test that we would do is the typical test we do for myeloma. We look for that abnormal protein in the blood with the serum protein electrophoresis and the light chain. I'll just add one comment here to be super pragmatic. When we do test for people, based on the findings, it can influence not just their psychological well-being, but it can affect finances, and it can affect insurance, whether it's health insurance or even life insurance. If you fill out a life insurance plan and you've done extra testing and you found to be MGUS, that could influence your life insurance. So I would just also put that in the equation, that discussion should be had, and people can approach insurance whichever way they want. But sometimes when I'm having that conversation with patients saying, should I get tested, should I not? Some patients opt to make sure their insurance is settled first, not to game the system or beat the system, but just to be pragmatic. Because once that is discovered, it may affect people's eligibility for different kinds of insurance. What is the current best combination meds for starting treatment for having smoldering myeloma for 20 years that has now become active myeloma? Amrita, how are you going to treat someone who's become active after 20 years of smoldering?
That's a really tough question. I think I need more information there, right? In terms of age after 20 years, right? Frailty, other comorbidities, genomics, which again, it's like cooking, right? It's saying, how are you going to make, I don't know, curry, right? It's a lot of complex spices you got to put in there.
Okay, make
I am
me
a better
hungry
cook
now.
than Saad, I'm guessing, but I don't know.
At the same time, I also think, myeloma is myeloma, right? So when someone has active myeloma, have the conversation with your doctor about what is available. I think right now, in general, we're treating people with a quadruplet. We have very strong evidence and FDA approval, whether they're going to transplant or not. And that quadruplet typically involves Revlimid, dexamethasone, either Darzalex, daratumumab, or isatuximab, or Cyclisa, and then a proteasome inhibitor, usually bortezomib, sometimes carfilzomib. So I think most of us would follow the guidelines that are there, that it would be a quadruplet. As to which one is best for you, I would discuss with your treating team. And I'll add in this other, it's not really a question as much as a comment from a patient, or from someone who submitted a question saying, no current quadruplet induction achieves 100% MRD negativity, but the clinical trial with Majestic 5, it could be the new induction standard. Now, the caveat here is that this is still new, but what is Majestic 5? Majestic 5 was a clinical trial where we added one of the drugs that we now use later in disease, teclistamab, as a bispecific antibody. It's hard to believe we've hardly talked about bispecific antibodies, and they're such a big part of myeloma. But again, to be super simple, a bispecific antibody is called bispecific because it has 2 arms. One arm grabs onto the myeloma, the other arm grabs on to a local T cell in the body and kind of activates that T cell to destroy the myeloma. So it's a little bit like CAR T cell therapy, but you don't have to collect the T cells in advance and manufacture them and give them back. You just directly give this drug. And this clinical trial is looking at adding teclistamab to some of the drugs that we typically use in frontline therapy, like Darzalex, like Velcade, like Revlimid. And the numbers are small yet, but it is very, very promising. And just like Dr. Krishnan noted that there's clinical trials moving CAR T to the frontline, we're also doing lots of clinical trials with moving teclistamab to the frontline. And very recently, we had a third, if you will, class of immunotherapy drugs, something called belantamab or Blenrep, which is an antibody drug conjugate, which was just approved by the FDA a couple of weeks ago. We also have clinical trials with it coming to the frontline therapy as well. So it's amazing how much is changing in the frontline therapy in the very near future.
And maybe I can put a plug in here to, I guess the reason I said that about that patient is there are patients who don't get quads, and I don't know how old that patient was, who had smoldering for 20 years, right? So that's why the comment about frailty, because the 2 trials that I think are important studies, Majestic 7, that both Saad and I have open at our institutions, which is, what you're commenting on, Joe, about frontline use of bispecifics in patients who are not frail, right? They have to do a frailty score as part of the eligibility, and that patients have one arm is talquetamab plus CD38 len-dex, the other arm is teclistamab plus CD38 len-dex, and then the fourth arm is CD38 len-dex. So it is a randomized study trying to answer that, what is the optimal therapy? And then the other point is for more frail patients, there is a SWOG trial of quote unquote RVD light versus len-rev-dex. So, sort of to try and answer for what is the best frontline therapy.
Excellent. Thank you for that. So many questions here. Assad, my wife has 1Q gain. Is that considered high risk?
So in today's day and age, 1Q gain on its own is not considered high risk. If a patient has one of the other high risk translocations along with 1Q, that's the only situation in which it would be considered high risk. So 1Q alone, 1Q, gain 1Q or having one extra copy of 1Q alone, patients do quite well with the quadruplet induction treatment approaches that we have today.
Time is going quick, but we'll still take a few more questions before we wrap up here. Because we covered high-risk smoldering myeloma tonight, I'll take this question. What are your thoughts on CAR T and high-risk smoldering myeloma? I think one of the reasons why we highlighted high-risk smoldering myeloma as a controversy is that there are different ways of thinking about high-risk smoldering myeloma. Go back to my analogy. I'm getting close to the cliff, but I'm not quite at a stage where you would typically pull me off. Sometimes it may be reasonable to think about Darzalex monotherapy as a single drug or just wait and watch. But other people are saying maybe if we catch the disease early enough, we might be able to truly cure it. We see this in some certain solid tumors. If you can catch breast cancer early enough, one of the reasons why we do mammograms as much as we do is you might be able to actually truly cure it before it becomes a bigger problem. And so some clinical trials are being very intense in treating high-risk smoldering myeloma, some of them with a bispecific, some of them with CAR T, some of them with combination drugs, not just Darzalex. But we highlighted Darzalex tonight because it was recently FDA approved, and that was the most advanced of the clinical trials. So more to come on that in the future, of course. Someone asked, can you get the IEC colitis from Tecvayli? Saad, do you want to take that one? Have you seen the IEC from patients on bispecifics, in particular Tecvayli?
My answer is no, because IEC colitis really is, more associated with CAR T or CAR T related therapeutic approaches. However, patients who go on BCMA bispecifics can develop some GI symptoms. This is something that we have observed, but they are not profound the way that we see with CAR T patients. So I have had patients who come to me with issues like loose stools, etc. But we haven't seen something like that. Amrita, your thoughts?
Yeah, no, I agree with you. It hasn't been, because some of it is felt to be more related to the CAR Ts in terms of actually in trafficking to the gut mucosa, depleting the B cells and that IgA protective immunity of the gut mucosa, which you don't get when you use an antibody, right? They're not specifically going to traffic there. So, mechanistically, one wouldn't expect it as well. And I haven't seen it either. I think probably because of that reason, it's pretty unique. It's sort of like the graft versus host disease, but of a CAR T, really.
Yeah.
I'm going to wrap us up here with just a couple more questions. I love this question, so I got to take it. Can we take any treatments without dexamethasone? Whoever you are, questioner 107, I love you. We have been talking about this for a long time. About even earlier this year, the wonderful nurse practitioner I work with in clinic and I wrote an editorial in one of our journals called "Down with Dex." And I think the myeloma community is starting to see more and more that we can be very effective in our treatments with myeloma with less dexamethasone. So we're starting to use lower doses off the start and then tapering it down even more quickly. I won't go through all the details of it, but definitely something to discuss. I think as we're using, discuss with your doctor, as we're using more effective therapies, the actual role of dexamethasone is going down. It used to help boost therapies. It reduced certain kinds of reactions. It actually helped with nausea, and it also helped a little bit with pain. So that's one of the reasons why we love dexamethasone. It does all sorts of different things. But typically, most of that benefit is had in the first cycle or two. And I think we're seeing many more treatments now where we can use less and less dexamethasone. I'm sorry I can't get to all of these questions. There's so many of you. We are cataloging them. I'll answer many of them in upcoming videos. But I got to take this last question because it really looks to the future and it excites us about what's coming. Someone asks, if anito-cel became available, would this be the new standard of care for CAR T? What about in vivo CAR Ts or trispecifics or cell mods? Wow, this person has definitely been keeping up with the future of myeloma. And please stay tuned to the discussions we're going to be having after ASH to discuss all of these. But in short, we have amazing tools now. But as both of our speakers indicated during their talks, we're still developing even better ones. New CAR Ts that have less side effects, CAR Ts that actually we might be able to manufacture in a patient, what we call in vivo CAR T. And even more extreme, something called allo CAR T, where we've actually pre-made CAR Ts from healthy donors, and then we just directly give them to the patient. I've joked about someday I'll go to Costco and I'll be able to buy T cells or CAR T cells and be able to use them. Obviously, that's not the case, but the idea of being able to have those right off the shelf. We've talked about bispecifics tonight. Well, if I had a third arm, I'd tell you about trispecifics, drugs that can hold on to the myeloma even more effectively as they seek to destroy it. New drugs called cell mods. You could read one of our booklets on cell mods in the IMF resources. These are drugs that are oral, very easy to take pills that we think are really going to further deepen the response in myeloma for many patients. So there is a lot more to come. Tonight, we tried to cover a few topics. We tried to cover a few questions. I'm so delighted to see the depth of interest in these questions, and we'll seek to answer them as much as possible in the upcoming presentations and videos that we do. In the last minute that we have, let me quickly remind everybody that you have a survey that will pop up as soon as we're done. Please take it, please fill it out, please provide us feedback and input as to our session tonight and things you'd like to have in future webinars. We would really appreciate your input. It means a great deal to us as we plan these different strategies together. I also want to take an opportunity to thank our sponsors again who supported this meeting tonight. I do want you to know that there will be a replay, so you can download this and watch this again if you wish. Here are the list of our sponsors. And then lastly, I just want to take a moment to thank both Dr. Krishnan and Dr. Usmani for their time, for their intelligence, for their passion, and indeed for their incredible contribution to the myeloma community. They're friends of mine, they're colleagues. I respect them both so immensely and really appreciate the time that both of you took to join us tonight. So thank you, Saad. Thank you, Amrita.
Thank you. It was a pleasure to be here and to chat with both of you. We always love to talk about myeloma.
We are myeloma nerds, that we are. Well, thanks everybody for joining us tonight. I hope that the rest of your night or day goes well whenever you're watching this. And please come visit us at myeloma.org. Reach out to us. We're here to help you through your journey. Thank you so much.